Thank you very much for the introduction. It's my great honour to share some of the work that I think is pioneering in many ways, and we're proud to do it in South Australia, in Adelaide as well. We all know that hospital readmissions are a major cost and a major detriment to not only patients but also the hospital system. One way that we try to prevent against this with an information outflow is the discharge summary. At the moment, it's, especially in electronic medical records, is extremely unstructured, contains free text, and we really struggle with how to optimize this process, getting information out to the outpatient setting. One way that we've thought could be of utility in going into the future is natural language processing, which a lot of algorithms are constantly coming out in the modern society, but really the process is trying to provide structure using computer algorithms to currently unstructured human language. This is a cartoon representation of some of the most common algorithms that are used, which are, funnily enough, actually, the acronyms actually are BERT, BART, and ERNIE. One that we looked at in this study was BERT, or bidirectional encoder representations from transformers. But the point that I want to emphasize is that because new algorithms are constantly coming out, we didn't look at specific sort of algorithms, or we weren't sort of focused on that. We were more sort of looking at the process per se. So our aim was really to look at natural language processing as a methodology and see its utility in predicting 30-day readmission when we applied it to the unstructured electronic medical record discharge summary. We're grateful for the Central Adelaide Local Health Network Ethics Committee for approving this study. And within this, we looked at general surgery readmissions at two of the major metropolitan hospitals here in South Australia over a 2-year period. We extracted the free text discharge summaries from them and then pre-processed the data but separated it out temporally. So the derivation training set was the first 12 months, the derivation testing set was the following 6 months, and then finally we provided a validation data set in the final 6 months of that 2-year block. We used, or we tested logistic regression and birth models on that derivation training set and then used that to predict a 30-day readmission. Overall, we had just under 13,000 general surgery patients included, and about 12,500 of them had discharge summaries. Overall, what we found is that the natural language processing process is actually pretty poor in predicting readmission. Logistic regression had areas under the curve of about 0.5 to 0.6, and similarly the newer model, BERT, had similarly poor performance. So it got us to thinking, why would this be? Well, most likely it's probably because there's a discontinuity in data after a patient's discharge. People go out into the community, they have interactions with a lot of sociocultural factors that we're probably not picking up with information just in the inpatient setting. So we thought that potential methods of collecting this in practice could be applications on smartphones, post-discharge surveys, and also phone calls or phone clinics. So we looked into this further, and we actually found that sociocultural and demographic factors do predict readmission, and sometimes a lot more than the actual clinical variables in hospital. Things like sex, the primary language, whether they have religion or not, comorbidity burden, and of course age. We took this a step further and then formalised this within a conceptual framework that we've submitted for publication. And within this, we want to characterise that there's always patient, surgery, system and society factors that are always affecting the outcomes that we treat within surgical patients, because there's information flow between all the levels as well. To sort of cross-reference that, we looked at an inpatient metric of discharge, or hospital discharge, and we found that natural language processing actually predicts it very well. So in contrast to readmissions, the logistic regression and BERT models had areas under the curve of about 0.8 or higher than 0.8 in that. We looked at this aspect a bit further using just objective data, and we're actually very proud of this work because it uses objective measures of vitals and blood tests, and we've named it the Adelaide score, and it accurately predicts discharge within the next 12 to 24 hours. Being in Adelaide for the conference, you may have seen this. It's actually gained attention in the local media. And we hope to use this attention to go towards what our main goal from this work is, which is a clinical trial. And before artificial intelligence can really be integrated within surgical systems, it does, of course, need an implementation trial and shown to actually benefit patient outcomes. That's what we're trying to do at the moment with all of this work, but particularly the Adelaide score.